questions.
So we always start with an acknowledgement of country. In the spirit of reconciliation, we acknowledge the traditional custodians of the land on which we meet, the Wurundjeri people of the Kulin Nation. We pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples here today, for they are the safekeepers of memories, traditions and culture. We recognise their connection to country, land, sea and community, and the role in caring for and maintaining country over thousands of years. May their strength and wisdom be with us today. So a little bit of housekeeping. If you can keep muted unless you are chatting, and please ask questions via the chat box. If you are a regular of the Community of Practice, you'll know that that's where most of our comments and conversations stem from. If you wish to raise your hand and speak up directly, we encourage that as well, and we'd love you to participate. The session is being recorded and you will be provided with access to the recording afterwards. And please ensure you join the session name using the name you registered with so we can mark your attendance, which is crucial for certificates and CPD points. So this is a little blurb which I'll let you read through on how to change your name. If you click on participants and then click on your name, depending on what modality you're joining with, and then you rename yourself with whatever you registered with. So this evening, I'm doing the welcome and introductions. Congratulations to Shiv, who has a brand new baby. So we're keeping him on mute in case the baby decides to join in. But very many congratulations from everybody here at the COP. And then we are very lucky to have Zoe Beddoes from the Waterwell project come and tell us about the work they're doing. And then Dr. Joanna Lawrence from the Victorial Virtual Services for Asthma. I'll be chatting some more with Shiv over some case studies and then go through our usual health pathways and wrap up and feedback. By the end of the session, we hope that you can implement best practice management for asthma in children, describe resources and local services available for children living with asthma, identify collaborative multidisciplinary opportunities to improve the care for children living with asthma, and perhaps interpret some local data and identify potential solutions to improve asthma care locally. So this is the part where we introduce ourselves, see who has jumped on to join us this evening. If I can just get you to log onto the chat and pop in your name, who you work for and what your role is, that would be fantastic. It's brilliant to see all our asthma nurses from across Western and Central and Northern Melbourne with us this evening. Oh, we've got a maternal healthcare nurse with us this evening. I think that might be our first. Welcome, Tanya. Great. I'll let you keep on introducing yourselves. So we're introducing our facilitators, but Catherine's not with us this evening, it's Shiv. So Shiv is lead in paediatric asthma at the Royal Children's. He does a lot of work with them and we welcomed him as co-facilitator to the COP last year. Very lucky to have him and his expertise here. And me and my very close-up picture, I'm a GP from Truganina. I see a lot of allergies, a lot of asthma and a lot of peds, so it's an interest of mine and I've been working with the Community of Practice for 2 years now. Zoe, do you want to introduce yourself or do you want me to introduce you?
Either, you go for it, that's fine.
Okay, so Zoe is a nurse and midwife with a diverse background, including emergency, juvenile justice, community nursing and maternity care. Currently, Zoe divides her time between providing comprehensive maternity care in a public hospital setting and serving as a part-time health educator for the Waterwell project. She's dedicated to working closely and with culturally and linguistically diverse communities, how we are called communities, both locally and internationally, aiming to enhance literacy and promote equity within migrant, refugee and asylum-seeking communities.
Beautiful. So I'll just get my little slide deck up. Thank you. Thanks for having me. So the Waterwell Project, we are a health promotion charity that works alongside multicultural communities to enhance health literacy. And we were started 13 years ago by a young intern doctor. She's the daughter of parents who fled Vietnam by boat in the late 1970s. And she really saw the gap between her parents' experience of accessing and understanding health information and sought to work towards a change. So we do that through providing community-based health education sessions in migrant, refugee and asylum seeker communities, and they are facilitated by health educators like myself or volunteer healthcare professionals. So just a little snapshot at last year for us, 310 health education sessions, 44 different topics, and we've reached over 5,000 community participants. Asthma was one of our top few topics that we ran sessions on, among other women's health topics and allergies as well. I think what's important to point out is that number of 5,000 is likely to be significantly more, as many of these communities are really tight-knit, motivated to learn and keen to share information. And we had 118 different healthcare professionals volunteer and give up their time to facilitate these sessions, which is wonderful. So mostly doctors and nurses, but a small number of allied health and AMBOs that cohort too. These are just a few of the organisations that we have partnered with in the past or are currently partnering with. And so my role, I've been in my role since August of last year. I'm one of 6 health educators. So we've got a couple of GPs in New South Wales. We have a physio in Tassie, an OT and a couple of nurses in Victoria. Lots of project work, so that might be satisfying grant requirements for particular LGAs or cultural groups or specific topics. So for example, last year we partnered with CoHealth to deliver asthma sessions, and we promoted the community asthma program within those sessions. A big part of my week is also facilitating health education sessions, and this is where we maybe can't get a volunteer to cover that particular session, or there's you know, specific skill set or approach that's required. Big part of my job is also developing resources, so our sessions are really interactive, and it's important that we have physical things for people to really embed their learning. So it might be, you know, a breast model with different lumps or bumps, or it might be in our asthma kit, different spaces or MDIs or anatomical pictures of, you know, your airways during an asthma exacerbation in a normal way. Also support our new volunteers, so I might co-facilitate a session with them, or send them, you know, a email and information before their session and debrief afterwards as well. And then just community engagement with our partners. So our community partners have their finger on the pulse of their communities. So it's really important that we're well connected to make sure that we are effective and responsive to the needs of their communities. So what do our sessions look like? Here's a few different pictures. So communities request us to go in, and that might be in schools, so primary schools or TAFEs or unis, playgroups, or different grassroots organisations, and each session is tailored to the group that's in. So there might be 5 participants or 70, and it just involves a community group gathering around the room and talking about the particular health topic of choice. So very interactive sessions. We welcome storytelling and, you know, people sharing their experiences. so that everybody in the room can learn. We have language support, often through a bicultural worker or by an interpreter through TIS. We've got a pro bono arrangement with them. It's a really unique situation to be invited into a community. People feel a lot more comfortable and safe to share and engage in that setting, and really we have the gift of time to go deep into the areas that people want to go into for their learning. I know that myself and the volunteers that we have certainly come away with our cups very full, just with the gift of hearing people's stories, but also the satisfaction of knowing that people are growing in their confidence in navigating their own healthcare journey. So getting to an asthma session, this particular slide just details one asthma session late last year. The picture, I wasn't able to get consent for a picture for this particular group, but they were of Vietnamese and Indian backgrounds, so I've just substituted a different picture in for that. So just a summary of the session itself and some different quotes that came out of the session. I co-facilitated this session with a ICU intern, and we covered a lot of ground and unearthed quite a few challenges, one of them being educating the whole family. About half of the group had a child with asthma or knew someone with asthma, but also acknowledged that they might have a friend, their child might have a friend over after school with asthma, so the skills and learning was really valuable for them. We used a Vietnamese interpreter and were able to talk through different scenarios. We simulated an asthma attack and then played the 4x4x4, and participants also had the opportunity to join in what they would do in that situation. So we knew that what had been taught had been fully understood because they were able to show that as well. This group was really interested in looking at the anatomical pictures of airways during an asthma attack and without. And just the comment there about not previously understanding what was happening in asthma before was really valuable for that participant, and particularly being able to marry that with the action of different medications, whether they're relievers or preventers on those airwaves, was really important for their learning. They also did a little simulation where we all breathe through straws just to simulate what it's like and how tiring it can be when you've got reduced airway capacity as well. So I guess in clinical practice, educating a family can be a challenge in any circumstance, but particularly if there's language, culture or health literacy barriers, that can be magnified. So it's obviously really important that we can address all of those things at once, as well as providing different options for people to explore, further education after the appointment itself. So what works in terms of educating the whole family? Definitely asking curious questions. So in this session, we asked, who else looks after your child sometimes? Is it uncle or grandma? And this particular participant said, oh my goodness, my mum would have no idea how to manage an asthma attack if it happened. So in following those curious questions, then you could ask, do you think it would help if they had an action plan in their own language? Bearing in mind that some people might not be literate in English, let alone their own language, but at least having the option to choose would be really useful. Short sentences, simple words, all those basics that we probably try to aim for in clinical practice, but just being extra mindful in this particular community. And then breaking down some of the jargon like trigger or reliever or preventer and asking, have you heard that before? Can you tell me what it means? To make sure that people have actually understood. Normalising the use of interpreters can be useful. Often there's a misconception people might need to pay for the interpreter, or also that it might be an added stress. But if we can normalise using an interpreter, it can take out that cognitive burden of trying to translate information internally, but also reduces the margin for error as well in understanding. And just stressing for people the importance of understanding information so they can make good choices for themselves and their families too. Particularly if you're seeing that person again asking, can I book an interpreter for our next session, just as an easy step that you can cross off the list. Using the teach back method, we find is really helpful. So giving a small amount of information and then having the person tell you back in their own words, just to know that things have been understood, because often the "do you understand?" yes isn't going to cut it. People may not have actually fully understood what we're talking about. So that's really an important thing to utilise, as well as other resources to embed learning, like pictures, whether it's drawing a quick diagram of, if you use a spacer, the medication is going to get to here on a, crude set of lungs that you've quickly drawn, as opposed to just staying in the mouth. Those sort of things really help. And being mindful that the way you teach someone might be the way they teach someone. So if it's a nice, simple, well thought out description of what to do, then that can potentially be the way someone else teaches them. And then just making things easy. At the end of a consult, can I give you a few copies of your asthma action plan, rather than them having to try and find a photocopier or those kind of things, and asking, if they would like an action plan in a different language for a family member or themselves is useful too. So in just preparing for tonight, I've spoken to other health educators and volunteers just about commonalities that we're finding in sessions. So we've just highlighted a few of these here. There's always people within our sessions that have no idea what to do in an emergency, let alone their options when they call 000, what they're going to be asked on the other end of the phone. Do they know the number? Do they know they can say ambulance diary and have a diary interpreter on? All those little tips and tricks, as well as making sure they stay on the phone with the ambulance. All those things are really important. Giving people other options for advice is really important. So people, often the role of the pharmacist can be underestimated. People don't realise that they can check the technique of using the spacer, as well as providing information about medicine, and giving other options, whether it's a link to a video of RCH material or Health Direct in language. Different information can be really useful for people too. I find in sessions that people are far more likely to engage with a video than be motivated to call a phone line and have that discussion. But sometimes we have simulated in the sessions or done a live call to TIS and then a call through to another phone line, just to show people how easy it actually is. And then a lack of time and confidence to discuss with a GP. So this might be because of previous experience or lack of language or different things like that. So enablers, essentially just being curious with your questions, having a really respectful and welcoming environment can go a long way. People's experiences, their pre-arrival experience might have been quite poor in terms of inadequate treatment or poor treatment. There might be a power imbalance or just the stress of having to retell your story. And particularly if there's been trauma in the past, we can work towards recovery by the way we interact with Zika and migrant communities. Often how relaxed we are does surprise people, and the collaborative nature that healthcare is becoming is really something important to reinforce, that people should be in the driver's seat of their own health, and we're just there to provide information and cheer them along the way. So creating a safe environment is really important, as well as acknowledging that people have wonderful skills and resilience, unique attitudes and knowledge of healthcare, and we're just there to build on that and validate experiences. So these can have big effects on people's wellbeing and health in general. So just a quick summary. Asking curious and collaborative questions is just so important, as well as creating that safe environment and making sure what we're teaching is actually landed in terms of using the teach back method. And also just safety netting with helping people understand there's other resources that they can engage with outside of that particular consult, and having appropriate options there for them, as well as making it easy by providing potentially extra copies of action plans as well. So just on this slide is a little bit of extra information about us. We're always looking for people to volunteer with us. It just involves doing an online or face-to-face induction and a little bit of admin to each topic. We have 50 different topics that we present, but each has a topic guide, so you don't have to start from scratch to find evidence-based and up-to-date information to use as content in your sessions. So I think that is me done. Thank you.
Fantastic. Thank you so much, Zoe. That was great.
Mm-hmm.
Maybe, Natalie, if we can get up and go to the last of Zoe's slides so people can take down those resources. And if anybody has any questions for Zoe, please pop them in the chat. While you're thinking of them, I've always got a question, Zoe. It's an incredible resource, one that I've heard of through the community of practice events, but not had any personal experience of. How do you mostly set up sessions? Do people approach you, or is there demographics and organisations that you actively go to offer your services?
Yeah, so we have more demand than we can satisfy. So it's communities approaching us. So we rarely advertise anything. It's more communities coming to us and saying, hey, can you present on this topic? This is happening in our community at the moment, and we'd love some extra support around that.
Okay, and they can contact you through Instagram or Facebook, or using that email?
So most of the time it's either through phone call or email. So we've got a project admin that works 5 days a week, and yeah, and that's how people book sessions.
Great. And specifically for those of us working in the community, we are really well supported by our community asthma programme. Our kind of very multicultural practice, we serve a lot of the CALD communities. If GPs, I mean, yes, myself, if the GPs wanted to get a community session regards to asthma organised, because this is the sort of thing I can advertise in my practice quite easily, but it might not necessarily come from one community. It might be a collaboration between communities. Is that something that you go to a GP practice, that if we organise something, or if anybody listening thought, well, actually we could maybe get Wednesday afternoon or Saturday morning or whenever you're available, and we could certainly advertise that to specific patient groups?
Yeah, definitely. All we need is a room and some chairs and some people. So it doesn't take much to run a session, and all of the inquiries just go through Della, who's our project coordinator.
Okay, that's a brilliant resource. I also had a question. I don't know if I just misheard you when you were talking about phoning and asking for an ambulance. Did you just say they could phone and ask for an ambulance, or was there a term there that you said, an ambulance? I didn't catch the second word.
So if you're saying ambulance Dari or ambulance Arabic, then the ambulance operator will attempt to get an interpreter on the phone. So people don't need to say too much before that's triggered.
Oh, I did not know that. That is a very useful resource as well. Brilliant. Okay, so ambulance and then language, and patients who have English as a second language, even if they do speak well in English, when you're distressed, it's always easier to do it in your own language. That's brilliant. We've got some questions from the chat as well. Kevin from Asthma Australia, Kevin Smith, is just wondering, what asthma pathophysiology resources do you use in your sessions?
It's just a really simple, so on the Asthma Australia website, there's the Living Well with Asthma in language, different modules, and there's just a really simple picture of 2 airways, and one has edema and musculature that's sort of squashing that airway, and you can see there's a smaller diameter, and the other one is a healthy airway. So very simple, but really easy to understand. I think it's even got a bit of extra mucus. Really easy to understand, just the basics of it in visual.
I'm sure Kevin will be delighted to hear that his resources are being used. Anybody else got any questions for Zoe? Anything else that they want to clarify? I think you were pretty comprehensive there. I'll let you have a think, and we can also circle back to it at the end. So I think we could pass over to our next speaker in the meantime, who is Dr. Joanna Lawrence. Joanna, are you desperate to introduce yourself, or would you like me to?
Oh, I can introduce myself. I'm not
Go
desperate
for
to,
it.
but happy to. Hi, everyone. I'm Jo. I'm a paediatrician. Worked for many years at the Royal Children's Hospital and worked with Shiv in the complex asthma clinic. And as of March last year, I've been working with the Victorian Virtual ED as the director of the paediatrics branch of the VVED. And I've also just taken on a role as the director of the Victorian Specialist Consult. So I'm going to share my screen, hopefully as smoothly as, no, definitely not as smoothly as happened before because I've lost my PowerPoint. Sorry, everyone. Maybe I'll just say next slide and we'll go with that option.
Take your time, Jo. We've got some time.
That's fine. My slides are, there's not many of them and there's not much content. So this is what I'm hoping to talk through today. Firstly, hopefully most people have heard of the VVED or the Victorian Virtual ED by now, but I will cover that off and then share with you our other virtual services which are newer. One is the virtual ward and one is, as I just mentioned, the Victorian Virtual Specialist Consults, which is a relatively new service as of March this year, and then how we manage asthma across those services. So the VVED was started in October 2020 as an initiative from Northern Health in COVID. And we all know that the Northern catchment got quite a heavy burden of COVID at that time. And there were a lot of people not seeking healthcare because they were concerned about visiting a hospital in that context. So it stood up as an initiative locally. They were seeing 8 to 15 patients a day in defined hours and only COVID patients. And fair to say it's spread and scaled quite successfully since then. So it is now statewide, funded by the Department of Health. It's available to every patient across Victoria from birth to death. And there are a number of pathways in. So we still get the majority of our patients are self-referral, particularly in paediatrics. So anyone in Victoria can refer themselves if they're thinking they might drive themselves to ED. And we're really encouraging people to reach out and use us first before they get in the car and drive to ED. And then we've got a number of partnerships with healthcare providers. So an important one is our partnership with Ambulance Victoria. We get redirect phone calls from AV secondary triage. If they don't think an ambulance needs to be dispatched, we can do a video consultation first. And we also get contacted by paramedics, on the scene. If they see a child or an adult who they have treated and don't think need to be transported to hospital, they can reach out and get a virtual consultation and some affirmation that that patient doesn't need to be transported to hospital. And that obviously frees the paramedic to get back out onto the road to the next patient, saving them ramping and the wait time at hospital. We get very few general practitioner consults, but our GP community are referring patients to access the VVED much as they would advise their patient to attend a physical ED. But we are getting calls from urgent care centres and also from Nurse on Call. So we partnered with Nurse on Call in August last year for the paediatric arm. They were directing 27% of their callers, and they get 11,000 paediatric callers per month to present to a physical ED via private car. And we said, well, we can see them quicker than most families can drive to ED, so why don't you send them to us instead? And so we've been seeing children redirected from Nurse on Call as well. I'll just get the next slide, please, whoever's driving. So this is our pathways in. The main point of this slide is self-referrals do come through a ED nurse triage first. That's a video consultation with one of our triage nurses. Their main role is to detect those patients that really should be calling AV with a life-threatening emergency and make sure they're not sitting waiting for a virtual consult, and also to avoid scope creep. So things that are long-term conditions or patients wanting certificates for work or long-term scripts, they will get redirected to primary care by our nurse triage, but in a really supported manner. So they're helped to book that appointment and make sure that there is access to care. Our healthcare provider pathways come straight through to see a clinician. And then the next slide, please. This is our paediatric data, given we're talking about paediatric asthma today. So we've seen over 20,000 children since inception. We're currently seeing about 250 children a day. So that's significant growth. When I started with the service in March last year, we were seeing 100 kids a day. That's now 250. The jump up in green, so green in the bar chart is healthcare professional pathway, and the blue is self-referral. So you can see it's still slightly weighted towards self-referrals, but that jump up is when we partnered with Nurse on Call and getting those 27% of their callers every day that otherwise would have driven to ED. And you can see we're diverting almost 89% of children that reach out to our service. We're managing their condition at home, and that's through a combination of being able to e-prescribe, to be able to admit them to our virtual ward, and just a lot of conditions don't actually need to be managed in a physical ED. A lot of paediatrics is observation. And our patient satisfaction is extremely high. I would challenge you to find any other health service that has such a high positive patient experience. And you can understand why. For anyone who's a parent, most of our calls come through in the evening. There's other kids around. Sometimes the other kids are asleep. So being able to access the care and the reassurance that they need to manage 89% of those kids at home has been met with a lot of gratitude and a lot of happy patients. If we could go to the next slide, thank you. So this is our asthma diagnoses. So this is of the patients we see, about 2 to 2.5% are diagnosed as asthma according to the ICD-10 codes. Now, we all know that our data entry as busy physicians is imperfect. So I suspect this is a significant underestimate of the number of children we see with wheezing illnesses or with bronchodilator responsive symptoms to our service that are given alternative diagnoses, but at least 2 to 2.5%. So that's at least 10 kids a day coming through our service with asthma. And if we go to the next slide, these are our adapted guidelines. So we haven't reinvented the wheel. We've used the RCH or the PIC guidelines as a basis, but we've adapted these for the virtual setting. And if you go to the next slide, this is one of the main differences, is that for moderate asthma, we're offering burst therapy in the home. So that's not commonly done. And obviously we're very careful about who we do that for. We're not looking for the patients who've been in ICU or received IV therapy recently, but those patients, and it's typically the preschoolers or the viral induced wheezers that time and time again end up in ED, end up getting a burst, and then sit there waiting for their Ventolin requirement to stretch. They're a perfect candidate for us to manage in the home, and we're doing that quite successfully. So on to the next slide. That brings me on to our extended care ward. So we have a virtual care ward that operates in a similar manner to hospital in the home. So we admit the patients, they're in their own home, and all our care is virtual. They have 24 access to paediatric review. So we give them a number and they can call that at any time, and one of our paediatricians will jump on and review them. And we have both planned and unplanned reviews. So the unplanned reviews is when the parent initiates that response because they're worried there's been deterioration. And the planned reviews are when we're seeing a kid, perhaps we've burst them, and we plan to review them in an hour and another hour after that. Since we opened this ward in October last year, we've had 25 kids with a diagnosis of asthma through the unit, of which most have stayed only a single night and some have stayed a couple of nights. And then I think the next slide is our heat map. Yes, so this shows our reach across Victoria and really shows it through word of mouth with spread right across the state of Victoria. And what has been eye-opening about this as a metropolitan-based clinician sitting in Melbourne is the really limited access some of these children have to healthcare. So I saw a child in Echuca the other night that had to wait 9 to 10 weeks to see their GP. For many of these children, it's the first time they've seen any paediatric expertise. And so when we first started, we were able, when we had the time, to provide really holistic, comprehensive care when those children reached out to VVED. We've now, with 250 children accessing our service every day, we now manage the acute episode, but we've looked for pathways where we can provide that comprehensive holistic care more broadly in another setting, and that's given rise to our VVSC pathway. So if I just go to the next slide and introduce you to the Victorian Virtual Specialist Consults. This model actually started, some of you may have heard of it as the MCVC model, and it was a co-consult with GPs. The idea was to replicate that corridor consult that hospital clinicians have the opportunity to have when they bump into their colleague in the corridor and they can discuss a case. We wanted to create that opportunity for GPs. So a GP could jump on our website, find the specialist they wanted to speak to, and book in a free 20-minute appointment. It was at the GP's discretion whether or not they wanted the patient there, and it was really about just providing that opportunity to talk through a case, provide more timely advice and management to that patient, and also help build the local capacity to manage those issues in the future. As we saw the need arise from VVED, we created a second pathway in with referrals from VVED. So any patient accessing the VVED that has an unneed healthcare met, we can create a direct referral with one of these specialists. And we've stood up dedicated clinics over time, one of those being the Paediatric Asthma Clinic, which I'll speak to more in a second. If we go to the next slide, it shows our pathways in. So we still, a core part of our business is the GP co-consult, but we also have these direct reviews with VVED referrals, and we're now opening that up to rural and regional centres being able to direct refer directly into our service. Of those that have used our service, our satisfaction is extremely high. Of the GPs who have engaged in a co-consult that have completed our feedback form, 99% report that the service has made a meaningful impact to their decision making. Of the direct patient referrals, our patients report a satisfaction of 4.5 out of 5, which is pretty high. For those that had a pre-existing specialist appointment on a waiting list, 38% of those have managed to be cancelled after a virtual co-consult. And of those that were planning to make a referral, 68% were felt to be unnecessary after the co-consult. Those that go on and have the specialist review say that they feel better prepared. They've had the early investigations and management instituted. So by the time they see the specialist, that time hasn't been wasted and they're able to get the most out of their in-person assessment. So I just wanted to turn now to our asthma program in the VVSC. This was stood up in collaboration with ICAM. So we have a clinical nurse consultant, Katie, who has worked in the complex asthma clinic with Shiv and I over the last couple of years, and before that as a community asthma practice nurse. Her role really is to standardise and support these patients who are reaching out from across Victoria, who are getting their acute exacerbation managed by the clinician in the VVED, but really our VVED clinicians, because they are managing patients from across the state, aren't really able to keep abreast. Hannah, can you go let your brothers in, please? Sorry, that's my children returning home from tennis in the background. They're not out. We can't expect our 250 clinicians to be aware of every community asthma program, to remember to refer them to the community asthma program and to understand what the most appropriate local resource is. So we've centralised that by a referral into Katie. She sees, it's a new service, so it started a couple of months ago. She's seen 20 patients to date, and really she's performing the modified magic. And I loved hearing about this magic, which is an ICAM initiative, which hopefully many of you have been introduced to. Because as VVED clinicians, we can prescribe, but we can't give that medication in hand. Katie's role is to make sure that medication script has been filled and that the patient understands how to use it. Interestingly, she's uncovered that a lot of clinicians are suggesting only to use the Flexitide or the preventer when the patient is unwell and not all the time, and that's coming from both GPs and external services. And so she's able to address some of those misconceptions and really explain what the role of the preventer is. She's able to ensure that everyone's got an asthma action plan and that it's in an appropriate language and format that the patient understands, that the importance of being linked into their community care has been discussed and there's a plan for that, that their inhaler technique has been checked, and that they're booked into the most relevant community asthma program for them. And then the final slide was really just highlighting her role in the medication, but happy to take any questions then now. And I'm just going to allow my kids to watch TV while I do so. Yes, you can watch the end of the movie. Always a multitask.
Thank you so much for that, Jo. It wouldn't be a cop without kids and dogs involved. So
we did pretty well getting through to 7:13.
Yeah, fantastic. Well done. Thank you. That was so interesting. I'll let the questions come in and I will ask my usual ones, which I've been noting down. So great to learn more about that service. I have patients that use it, but can I just practically, because when we're sometimes describing a service, it helps for patients to visualize exactly what that means. So a couple of questions I asked about the VVED. Obviously that can be telephone or video call when they call.
Video only. So if we consider an important part of our, you can watch it on the TV. Yep, just keep the volume down. We consider a really important part of our service is visualizing the child, and we know anyone who works with peds how much information you can get as soon as you see that child running around the room versus lying flat. And in fact, that's one of the key things we've learned that we can augment over and above the nurse on call triage is sometimes the story you're hearing via the phone versus the child you're seeing are quite different. So if we can't make that visual connection, we actually will not see the child or the family. So video consultation is a core part of our business. Yeah.
Fantastic. Yeah. I mean, I think most people with children these days probably would have access to video. It's probably an older thing.
And people use their phone. It doesn't need to be a laptop. So most of our consumers are joining via a mobile phone.
Yeah. For non-pediatric populations, will you do it over the phone for older populations? Or if it's something that maybe is an asthma, would you do it on phone call if that's all they had? Or do you still say no?
We still, and we get a lot of calls from RACF homes, so not related to this, but we do a lot of really good work supporting RACF facilities, and they're very good at connecting via video.
And when you say you give burst therapy over the home, so presumably you've got the video, you're watching them give it, so you're making sure they're giving it correctly. And then does the parent have to stay on the video call, or do you say they look better now, call back in 20 minutes? Like, how does that actually work? How do you stretch them in a virtual ED?
Yeah, that's a really good question. So it would depend on both the clinician and the patient. So I would often just watch the first dose and check that there's been some response. And then, as I said, normally these are patients who are quite experienced. They've been to ED a number of times. They feel confident that they know what they're doing. So I will just ask them to repeat that dose. 2 doses, 20 minutes apart, and I'll jump back on the line in an hour's time. I'll ask them just to reconnect to the same link, and then I'll look out for them in the Health Direct waiting room. We use Health Direct, and pick them up again and review them. And then on that review, we'll make a plan about when I need to see them again. Other clinicians do keep them on the line and watch a little bit more and do some education in between. So I think we all differ. But no, they can pop in and out of the waiting room. When we admit them to our virtual extended care ward, that really facilitates that. So that gives them a phone number that they can ring and speak to any of us to draw attention to them, or they can just pop into the waiting room and we'll see them there.
Yeah. And what are the sort of waiting times when they call?
Yeah, so we have committed, if they come through from a healthcare professional pathway, we've committed to seeing those patients within 15 minutes. A self-referral pathway can be anywhere up to half an hour, and that's to see our triage nurse. When our triage nurse sees them, obviously they can escalate if they think they need AV, or they can create what we call a category 2, and that's someone who needs to be seen sooner rather than later. So any child with asthma who is having difficulty breathing would absolutely be escalated to a category 2 and would be seen as soon as the triage nurse laid eyes on them. We also get, when they register, they put in what their concern is. So if we see a young child registering with work of breathing or breathing difficulties, they'll get bumped to the top of the queue and we'll see them sooner and make sure that they're safe.
Brilliant. The reason I ask is my local serving ED, I have a lot of patients who after the weekend go and wait, because it can be 10 hours, but it's just
absolutely
the way it is.
Yeah.
So they come home. So it's just really useful. Patients often will ask or use a service, but if they think they're going to have to wait 10 hours, so that's really, really useful. And for the VVSC, so that's serving the northern region, rural and regional.
That's serving Victoria-wide. Yep. So
Victoria-wide.
any GP in Victoria can use the co-consult service. And in fact, any nurse can use the co-consult service. So a community, I noticed there were a few community asthma nurses also welcome to jump on and have a co-consult with one of our paediatricians if you need support with prescribing medications and you're not getting that traction elsewhere. So any healthcare provider can use the co-consult service. The direct referrals we're really limiting to rural and regional areas where those specialties are lacking because we don't want to queue jump for a direct referral.
Of course. And I'm just going on here. I've just Googled VVSC and we can book it that way. Right.
Yeah.
And it looks exactly like the page you put up. Fantastic.
Yeah.
And thank you. We had a brilliant question from, I think, one of the GPs here asking, is it funded for someone without a Medicare card, all the services?
We would see everyone. Yeah.
I think Shiv's got his hand up too.
Hey Joe, you probably answered this question, I just missed it. Do you have an approximate wait time for the specialist consult?
So we have bookings the same week, essentially. Yeah.
And I guess on this call, so for Katie's clinic, I think there's probably there's a lot of overlap with that and what, say, CoHealth already do, and the DPV asthma program as well. So do you have a sense for like what would be better to come? And there's probably like a lot of GPs who could refer to any one of those services based on the geography. So do you have a sense for what would be best to go where, or or like when to use, say, a community asthma program as opposed to the what you've just presented? Or doesn't it?
One of the main drivers for setting up Katie's clinic was that it was really hard for our clinicians to know which community asthma program to link patients into. And obviously that's a really important part of supporting these patients have the best outcomes for their asthma. So I think the Northern Health are directly referring their patients into the local community asthma program. And we talked about whether there was a role for Katie's clinic for Northern Health and ultimately decided not to, because it's much easier if you're working in a catchment to know exactly which community asthma program to refer into. A lot of our patients, Katie is finding, actually don't have a community asthma program locally. They're in areas that don't have access to one, and in which case her role is even more important, I think, to provide that basic level of understanding. But an important part of her role was to sort of tease out that geographical distribution and make sure that patients were linked into their local community resources when they existed. And we thought that was better centralized in a single human resource than asking every single clinician to work that out on the fly.
Yeah, that's awesome. Thanks, Joe. I guess that's really helpful because there's probably people on this call who have really great relationships with, say, for example, CoHealth already. And I think they could probably, for the most part, just keep using CoHealth.
Absolutely.
Rather than, but anyway, yeah.
I think from a community point of view, I suppose it fills the gap for people who don't have a regular GP as well. So if you're seeing somebody in the community asthma program or ED or the VED, then you can refer to that service. And it sounds like a service who could probably link you in with a regular GP. And Hannah from CoHealth has explained that also the community asthma programs only have certain catchments. She's just popped that in the chat. So I suppose it's a bit of a wider catchment, although they can sometimes accept out of the area. And then just if anybody wants to know, Hannah's put the CoHealth catchment for the community asthma program of the Banyule area, just in the chat if you want to take that down if you're working in those areas. And Deb's asking if there's any growth funding to expand the community asthma program capacity. It's a great question. Who's in charge of that? Anybody here? There's silence after that, so perhaps not. Well, Joe, that was really informative. I think it's brilliant to understand how these services work and access to services. Again, coming from the community service, one of the hardest ways we work is knowing what's available and exactly how to describe that. To have a patient engage in a service, knowing more about it is key, and how to access it. And I will definitely be using more of those. there was just a couple of questions above that about Kevin, if anybody knows any other resources to describe asthma pathophysiology, and some people saying they had models and things. I Google images for everything now and just show people images. So I pick the image that I like the look of the best and that the patient identifies with best. So I use good old Google. I don't see any more questions at the moment. Any last takers, or we'll move on? We've got about half an hour left for case studies. Okay. Okay, so you get to hear more of me now. So here's some case studies. This came from some requests through the working group pre-winter to go through case studies, which are always helpful. These are my cases, but in the community, in the COP, we really try for you to bring in your own experiences. So if anybody has any experiences that are similar or linked that they want to share, please do. I'll go through what I did, and then you'll have advice from the expert, Shiv, what he would do, how he'd alter my care. So I'm putting myself out there in the hope that other people put themselves out there. And the topics were requested, so I've not come up with them. There were topics that we haven't talked about so much, so hopefully they're of use to everybody today. So the first case study was requested about children who have either neurodiversity or disability. I think often when we talk about asthma, we do protocols, we do services, we focused a lot on not so much straightforward asthma cases, but in terms of paediatric presentation, we've not necessarily talked about other complexities. We've talked about complexities of social circumstances and funding, but patient-specific complexities such as communication issues, social emotional communication issues. So I chose a patient of mine whose asthma isn't actually the biggest issue, but it was just the way I would approach a child who had neurodiversity or an intellectual disability. And this is a huge volume of the things I do. I was lucky enough to co-consult with Laura Marco for a year and have some assistance on how I do that. So I hope I'm doing an okay job, but we'll find out. So this is a lovely little boy who's 7 years old. He's a new patient and he has autism spectrum disorder level 2, asthma and peanut allergy. He's placed in his Gran's care at birth and he knows Gran as mum. And he recently moved to Melbourne from New South Wales for some more family support. He's not got an asthma or an allergy pan and he's starting his new school and they're needing them. And Gran or mum says asthma is well controlled. So taking asthma history, and I think if you're regular here or you're here tonight, you're probably pretty well versed in this. But just to explain the situation, asthma was diagnosed in preschool. He was predominantly wheezy and viral infection, and he was currently on Flixotide Junior, 1 puff twice a day and Ventolin as required. He hadn't had much Ventolin in the last 3 months when he last had a viral infection. He'd never been to hospital since his first diagnosis in preschool. He's not had any oral steroids in the community, and occasionally he'll get antibiotics. Gran reports he takes his inhaler well, but he doesn't have spacer. He had a peanut allergy that was diagnosed at age 1, and he's still in an EpiPen Junior. He's not seen any allergy services since preschool, and their main way of managing it is avoidance. He doesn't have any hay fever symptoms, not too sure about rhinitis, no other environmental triggers, and Gran's a smoker and she smokes outside the home. So in terms of history, obviously you're going to take full past medical history, medications and everything, but there's a few things I would specifically ask for any child who had increased needs. So for this child specifically, he's got a very restricted palate for texture and taste. He's still drinking formula from bottles, which Gran perceives will supplement his nutrition. He's never had a dental check. And he's in nappies during the day for school, but not at home. He can be incontinent with feces, so Gran prefers to keep him in these to avoid the embarrassment and management from the school. He was previously non-verbal, but has recently improved significantly with dedicated input from Gran, really. He's never seen a speech and language therapist. And he follows commands easily with minimal competitive behaviour. He's got a great bond with Gran, and he's really happy, easy kid to consult with. So social and safeguarding is another thing I'd be going through, especially for a child who's been placed in another guardian's care, and a child who has limited communication with yourself. So he's got NDIS funding in place, but no services as yet. It came through just before they left the state they were living in. Gran works 6 days a week on a minimum wage, and she's really concerned about her job security. She finds it hard to access services during working hours. There's no safeguarding concerns from Gran, but his father's imprisoned and his mother unfortunately has issues with IBDU and hasn't seen her son. There's no ongoing court orders or other forensic issues. Gran's family, her cousins and nieces, now support with pickups and drop-offs and respite because Gran's working so much. And she reports that their accommodation is clean and safe and damp-free. They don't have any pets. So how I assist this child? So first of all, we're an asthma cop, so we'll talk about the asthma. Really, we need to do the asthma plan. I kept him on his current medication. He seems stable, and my assessment of that was I've just met this kid. He's been stable on his Flixotide. It's been at least 3 months. I'm certainly not altering anything at the moment until I see him through a winter and see how he's done, get a better history and idea of how he presents with asthma. We obviously advised on using a spacer and asked Gran to buy that, which is a big financial cost for her. So also signposted her to some resources, which we talked about, to get cardboard spacers or anything that she can use. Anything is better than nothing. And ask her to bring it in to go through the use and show her how to do this. This isn't someone that I'd refer to pharmacy or another agency. I'm just building rapport with Gran and with the child. So I'm bringing them back to do the inhaler technique myself. I referred to the community asthma programme requesting a home assessment due to the social circumstances and Gran's working arrangements. Obviously did an asthma plan for school because it was quite straightforward, and supported Gran with smoking cessation. It's a tricky one with this because the child's asthma is pretty well controlled, and smoking cessation isn't usually something I nag people about. It's a really difficult thing, and I don't think nagging people gets them to stop. I think supporting people and understanding their view gets them to stop. She's doing everything she can. She wants to stop. She just can't at the moment. She's not really in a position to be prioritising that. So in terms of his allergy, he had a new EpiPen script as his weight was over 20 kilos. I think it's also out of date from memory. We did an allergy plan for school, referred to the Sunshine Allergy Service for review, skin prick and a possible peanut challenge because he hadn't been reviewed for 6 years. And we decided he should probably have some nutritional bloods, and we could always add a RAST into that. Next slide. And then other management, put them in touch with the local NDIS provider for access to speech and language, OT and dietitian around his behavioural issues, his nutrition, and requested them to get a dental check. He'd never had formal vision and hearing, so requested that because he was attending a new school, and asked for copies of the court order and custody to file, and treatment of chronic constipation on further investigation. A lot of the fecal soiling was just chronic constipation and him not being able to verbalise some of the pain signals and sensations he was having. So in the follow-up, they didn't come back. I thought it went well, but I bonded and made a good assessment. Spent 40 minutes with them. And 6 months later, I received a brilliant letter from a paediatrician up at Werribee who was doing a school inReach project, and outlining kind of what we discussed and the current issues that hadn't really changed. And I put on a recall request to Gran. And Gran came in pretty quickly, within a week. And really, she just sort of said, "Hey, not seen you in about 6 months. What's going on?" And really, she was saying she was living hand to mouth. She was really fearful she'd lose her job because it had happened in New South Wales because of the amount of appointments she was having to go to. And there was just a huge burden of appointments. What we were asking her to do between speech and language, OT, dietitian, community asthma programme, dentist, vision, hearing, allergist, it's a full-time job. And I think we have to remember that when we're dealing with children who don't just have asthma, but have increased care needs, increased burden of appointments. How do you actually do that? How are you going to support the caregivers through that? One thing I did notice is the patient had such a significant improvement in language acquisition. And I took that as an objective thing because it's easy when you see people who don't follow up to think, what's going on? You know, there's a history of a child being placed, you don't know the family, and the child can't give you too much history yourself. But there was clearly so much an affection and bond with Gran, and his language had just absolutely bounced forward. And Gran really said that she'd been putting a lot of time and effort into it, as had all her family caregivers, and he was obviously thriving in the situation he was in within this new family setup in Melbourne. So we did some simple things. I said, look, what's your boss like? Are they reasonable? And she said, yeah, but she really had this fear. And I said, you just need to come here for a care certificate. Phone me up, put a request in to reception, spot billed, or just ask for it. And I can give you a care certificate just to cover to say you have every appointment. And let's start to get the basics done. And we've got dentists in our practice. So we went along to the dentist that day and got a dental check. He got vision and hearing, which was all fine. And we started to engage in the allied health services. So I suppose my general points from assessing any child with increased care needs is, I really loved what Zoe was saying about curious questions. We all know how to take a history, but in the busy life of general practice, this was a 10-minute appointment, you know, and you need time and you need to ask the questions, especially as a child is non-verbal. Obviously, a 7-year-old doesn't always tell you a huge amount of history. Usually the 7-year-olds I see do, but the older the child, the more we expect them to participate in their care. So you really need to know what stage the child is at, what communication ability they have. You may have a child with quite advanced cerebral palsy who understands everything, they just can't communicate with you. So it's really asking, how does that child communicate? How do I ask the questions? And asking those really curious questions about all areas, including the asthma history. And to help facilitate that, really using your GP management plans, your team care assessment, and your child with a disability health check item codes to give you the extended time you need to be able to do these assessments. I would say something that I probably don't do as standard as a respiratory examination, but I would do in a child who had any form of communication issue, is an oral examination in dentition. I have a huge number of children who have poor dentition at our practice. And if you have a child who refuses inhalers or spacers, you need to know that their mouth's okay, there's no ulcers, missing teeth and cavities, and really encouraging that as part of basic care. Something which we would do with all children, but is introducing spacer inhaler as part of play. I think with all children, getting them to play with it and getting them familiar with a device before you trying to give it in an emergency is always useful. And to do this, again, we don't have endless time, but showing parents and caregivers and using our services such as the Community Asthma Programme, who are brilliant at it, and I would love to hear their views on it and how they approach it. But also engaging the speech and language therapist and the OT specifically when you're doing referrals, saying there's oral aversion, there's sensory processing disorder, there's been poor dentition, perhaps this is a reason due to the texture, the dietitian, but also use of inhalers if you've got a child who's struggling to use inhalers. Something that I always say is don't be afraid to ditch the mask. I think we often keep children, especially children who don't necessarily communicate with us, on a mask for a long time, and it's actually quite a claustrophobic thing. Again, for a child who has a sensory processing disorder, it is not a pleasant sensation having a tight-fitting mask over your face. And most children I know can suck a lollipop, and I think if you can suck a lollipop, you can use a spacer pretty well. It's just about building people's confidence with it. But often I'll see older children who still have the mask, and I say, "Oh, what are you using that?" I say, "Oh, we didn't know it came off, or we didn't think they'd be able to do it." And just actually showing them and assessing yourself, where you can actually take the mask off, and it's not too difficult. And then really the main thing is such a non-clinical focus is on similar to the smoking cessation, not always prioritising the immediate clinical care. You can only give good clinical care, find out the answers to barriers and challenges and what's actually preventing good clinical care. If you stop focusing on the immediacy of, oh, this child still drinks formula from a bottle, oh, they're still wearing a nappy at school, this child's actually thriving and things like communication are coming along really well. Those things are important, but why is that still happening? So for me, it was ask the caregiver's immediate priorities and concerns. And I didn't actually ask that in the first appointment. I was too busy asking all the clinical stuff and trying to get all the information down. And it was clearly there. She said, I work 6 days a week and I came here for more family help. And I gave her my list of priorities and concerns, which was a whole A4 page, which I printed off, documenting everything I needed her to do and thought she should do. And other than job, I didn't say, what's your priority concerns? And for her, it was communication and earning money, not losing her job. Asking about specific barriers to care, so not waiting for patients or caregivers to say, actually, I'm finding this really hard. Say, what is going to stop you accessing this huge list of obligations that I've thrust upon you? And then again, from a community support, I'm also now Grand's GP, but asking about the care's own support. How are you coping? This seems a lot. How are you managing all this? I would find that hard. How are we going to support you? Asking if they have any outstanding physical or mental health issues that we need to help support them. And then really seek to understand the child and the carer's point of view. In all of his clinical health letters, everybody said about the nappies and the fecal incontinence, but from their point of view, it's managing a difficult problem really well, and it's not the most immediate of his needs, and it's not what they wanted to focus on. And you're never going to get anywhere with anybody unless you really do that collaborative care, working on what a child and carer's point of view is. So I think that is everything. Yep. We'll pop back. Don't give any surprises about case study 2. I've not been monitoring the chat, so Shiv, have you been looking? Has anybody got any questions?
So I think Amy commented about ditching the mask and building capacity, and I think those comments resonated with me also, just as in, like, even in like the very subspecialty niche area I practice, sometimes there are like multiple issues to deal with and you can't always deal with them in one visit, and it's about asthma, particularly because you often are going to need people to do something every day. You really need to have a good therapeutic relationship. So I think prioritization is really important. And ditching the mask, I love, and I think it's a really good idea. And the other thing to think about, just when you said about the financial implications of a spacer, Amy made a good comment about being able to access free spaces from Asthma Australia. The other thing always to think about that I don't think any of us, myself included, think about enough, although to be fair, not so relevant to a child with disability, is maybe switching to a dry powder inhaler, because I think that probably a lot more children and young people can use them than we realize, and then you don't need a mask or a spacer. So certainly any adolescent, but even actually probably for most probably primary school age children can use them as well. So anyway, that's just something else to think about. But I'm not sure if other people have comments.
I think that's it, and Amy's put it really well there, building capacity. I think unless you are a caregiver yourself for a child who has a significant disability or neurodiversity, it's not in your immediate skill set to see what they can do. And also parents sometimes I see will think they can't do it with the child because a healthcare professional has sometimes led them to believe that they can't do it. And I think we always need to be looking for what people can do, as opposed to saying, oh, we'll stick in the mask because it's easier. The parents are comfortable with it. Yes, for the time being, don't say don't use the mask. But a lot of the things I see are behavioural difficulties. And I really try and think, well, what is it that the child's trying to do or communicate or try that we're maybe not letting them? What are we thrusting on them that is maybe beyond what they have capacity for? So I think, yeah, always sort of thinking outside the box and not just thinking, well, this seems easier, this seems straightforward, or this is what the parents have told me can do, and trying other things just to see if it works. I think Amy had also asked how the virtual ED consult works with children with significant disability and neurodivergency. Maybe Jo, you could speak to that if you're around.
Hi, I'm around. Sorry, what was the question, Kirsten?
Just how does the virtual ED consult, and how do they find assessing children with significant disability or neurodivergency?
So it's actually helpful to be able to assess children in their own home through the VVED. I think that is one of the biggest benefits the VVED brings to emergency assessment of children. So we all know that children with autism in particular find it difficult to be in hospitals and in a foreign environment, and often that colours the way we're interpreting their behaviour. So to be able to assess them at home, I think we get a much better picture of how they're coping. Obviously, we're focusing just on the urgent presentation or the acute exacerbation of asthma if it's a child with asthma. But yeah, and then the parents generally know all the strategies needed to enhance compliance with the spacer and things like that. So if anything, I think it's an easier way to assess children. Yeah, although
I think that could be very true, especially if your child's had a 40-minute wait to see us in clinic. Brilliant. Okay, in the interest of time, if you've got any more questions, just pop them in the chat. I'll just pop on to the next case study, which involves some community participation. So this is amalgamation. It's mostly based on one child, but it is a common GP situation. This is again requested of the intermittent preventer. I don't mean a preventer for a couple of days when they're well. I mean seasonal preventers. So we discussed within the working group seasonal asthma that is environmental, such as cold weather or pollen, is quite a lot easier to predict because you've got an environmental construct that comes around every year. There's always going to be high pollen in spring and summer, and probably quite easy to make the decision for a child who's got chronic hay fever that they flare in spring and summer and they need their preventer. Similarly, those who are triggered by cold weather and start coughing every time the weather starts getting cold and get a bit queasy. The ones we had discussed were the viral trigger asthmas that cluster over winter because they get more viruses in winter. So this is a pretty typical GP presentation that doesn't necessarily fall exactly within protocol, and it's when do you start the preventer? So 5-year-old female attends with mum and dad. She's had preschool asthma diagnosed age 3. This will be her 3rd winter. It's a viral trigger. There's no coexisting atopy or environmental trigger. Dad's got mildish asthma. The non-smokers are vapors and they don't have any pets. So she was diagnosed after 2 hospital admissions requiring burst therapy and oral steroids, a diagnosis, and she was commenced on Flixtide Junior 2+ BD because these are clustered together. So that had been done in hospital. She was referred to the community asthma programme, who she saw, and they had some really good input, and she was discharged after 2 to 3 months. And then she was very well through spring and summer. She hadn't had any Ventolin use for 6 months. And about the end of January, we stopped her preventer. So about late February, early March, she had one mild episode. They didn't come in, but parents have said they'd used a bit of Ventolin. It settled after a couple of days. It was mostly cough, might have been a bit of wheeze. They didn't really know, but they were pretty convinced she had some Ventolin and it had got better. And then I saw her again when she attended with several repeated asthma episodes over the autumn-winter period associated with viral infections. So she'd had some coughs and colds that hadn't had asthma, 1 or 2 minor ones, but 3 biggies that had come in. And each episode had required Ventolin, 2 to 4 puffs, given as required for up to 5 days over a 2-month period. So she'd had the real big one at the beginning, one about 2 weeks later, and then one about 4 or 5 weeks later. When I saw her, she'd always had some wheeze, an asthmatic type cough. It wasn't particularly severe, and she'd responded to 2 or 4 puffs of Ventolin, whatever we'd given that day in clinic, and she'd never needed it more than 4 hourly. She'd never needed more puffs of Ventolin. And by the end of the 3rd episode over this 2-month period, we said, look, really, it's starting to look like last year. We know she was quite bad last year. It was only about May then, and we started Flixtide 1 puff twice a day in the 3rd episode. She'd been starting 2 puffs the year before, but really she'd been quite well, so we thought, let's just start at step 1. And parents had really said, look, there's just this high burden of asthma symptoms. We worried about her going back to hospital, and she's always at the GP, time off school, time off work. So that's what we did, and she responded really well. She had one other viral, she had lots of viral infections over winter, but nothing really needing Ventolin. She had one later in winter, where she was quite sick, same thing again, needing Ventolin regularly. And I increased her Flixtide to a couple of puffs for 4 weeks, and then reduced it back down to 1 puff, and that maintained symptom control. And then she referred to CAP again, just to improve education, understanding what are asthma symptoms, what are not asthma symptoms. And again, she was fine over spring and summer, and we stopped her preventer after 6 months. So it's winter again. This year, she's come back. And again, they said there's perhaps a mild flare in summer. They'd gone abroad to a country that was very hot, very humid, very polluted. And again, this sort of vague history. Yeah, we gave her Ventolin. She was coughing a bit. Hadn't seen her. But otherwise, very well until this attendance with viral trigger, wheeze, cough, again, responding to as required Ventolin. So my question is, what would you do? We should have a poll. If the poll's going to work. Here we go. So your poll. Do you start Flixtide Junior again? It's her 1st episode. It's May. Do we start Flixtide Junior 2 puffs, which she's required in the 1st year and towards the latter half of the 2nd year? Do you start Alvesco, different agent, once a day? Or do you watch and wait and see what happens this year? Just to recap while you're thinking, she's not got any other associated risk factors. Perhaps now there might have been an environmental trigger, but certainly it was hot, humid pollution, not cold, windy weather, cold, windy, wet weather. Mild family history, but nothing else that triggers our asthma really, apart from these viruses over winter. While everybody's doing that, I'll maybe explain my theory before. So in the current asthma plans, it says increase Flixtide when unwell for a period of days. And Shiv, you can tell me your thoughts on this. I usually, especially if I know that they can get bad, will do it for about 4 weeks. And my theory on this is viral inflammation and cough can last 4 to 6 weeks. And we know that when she's been bad before, she clusters. She does the usual kid thing at that age of getting a new virus every couple of weeks. And on the back of a big wheezy episode, her areas are more reactive. There's still residual post-viral inflammation. So in my head, she is more at risk of further asthma episodes if we just increase it until she's better. So I tend to keep them on it just for that little bit longer to make sure they're really good. Any microscopic inflammation or irritation is definitely gone. The cough's definitely gone at night. Everything's really well before popping them back down to 1 puff BD. And I've never seen that in a recommendation. I don't know that I have discussed it sometimes with pediatricians and things, but it just seems to be something that I wouldn't do it for every kid, but kids who really have the viral trigger and you know them and you've seen them do it, and you know that probably off the back of this one, they're just going to get sick next week and need to increase it again. That's what I do. What's your opinion on that? Am I doing the wrong thing?
No, you're definitely not. And in fact, just to be clear, so the first thing is there's in childhood asthma, there's no role for in someone who's on a daily inhaled corticosteroid, so say Flixtide 1 puff twice a day. There's no role for increasing that dose for a short period during an exacerbation. So even though the asthma action plans kind of give you that option, you shouldn't do it. So the fact you're not doing that, as in you're not increasing it for a few days, I think is excellent. So the other part of and the reason being that there's like kind of good evidence to show that that doesn't work. So there was in fact a trial where patients were randomized to either stay on their maintenance dose or quintuple their dose. So go from taking 1 puff in the morning to 5 puffs in the morning. and they showed that that quintupling the dose did not reduce the rate of severe asthma exacerbations, but it was associated with reduced linear growth. So actually that's just not helpful. So you definitely shouldn't increase it just for a few days. What is reasonable to do, though, is what we should always do with inhaled corticosteroids is regularly review and titrate the dose, kind of with the idea of it's not going to help me today or tomorrow, but do I need to get myself or get the patient more protection in 2 to 4 weeks from now? And in that setting of someone who's likely to have back-to-back viral infections and often cluster, I think it's a very reasonable thing to go up and maybe stay on the higher dose until you think they're through the at-risk period and then bring it back down.
Okay, good. Glad to know. And I think this is what this case study was about. It was really about talking those sort of grey areas where you're looking at first principles, pathophysiology, knowledge of the patient, what they've done previously. So on that, the results are in. 7 out of 11 would start the Flixtide Junior 1 puff BD, and 4 of the 11 would watch and wait. So I had a discussion with the parents, and I said, what do you want to do? Where are your nerves? What are we thinking here? And they really didn't want her to be on the steroids. They were still a bit like, oh, we don't know. And I said, all right, well, she's a year older. She's had one. I'll just watch and wait. She can always go on it. It wasn't too severe. And that was a discussion between parents and me and what they wanted. And I thought, you know, if she's back in 2 weeks and queasy again, I'll just start it then. They'll be convinced. So that's what I did. If they hadn't, if they just said, what do you want to do, Doc? What would you have done?
Yeah, so actually I was going to say something similar about and we actually didn't rehearse this, so it's not like in that I would ask the parents what they want to do, because like, let's just say they're really steroid phobic. They're probably, even if you prescribe the Flixitide, they're probably not going to take it twice a day, every day, even if either consciously or subconsciously, is my guess. So I probably would, but if it was a family who, you know, and we have those families who just want the doctor to make the decision for them. So they said, if I said, okay, try to do like a shared decision-making thing, and they just said, you just tell us what to do, you know, we trust you, you just tell us what to do, I would start. So I think in general, we're moving away from, you know, the evidence or guidelines would say that we should move away from asthma that's treated with Ventolin alone. And so whether that's taking some inhaled corticosteroid with each time you take your bronchodilator, or in the primary school age group, I think it's much more practical just to put them on a daily inhaled corticosteroid. So, and with that exacerbation history, I'd be worried that they're going to do the same thing over this coming winter, although you can never be sure, but I would probably start. Yeah.
Good. All right. Okay, so everybody's right. You can start or you can watch and wait if that's what the parents want. And obviously 1 puff, I know some people are tempted to go up to a high dose because they've been a high dose before, they're sick now, but I would always start low.
So that's an interesting point. So just sorry. So actually the GINA, you know, like the International Asthma Guidelines came out for the 2024 version, came out about a week or 2 ago, and in it they have a table that I believe it's the first time they've had it. I don't believe it's been in the previous versions, although I might be wrong about that. But I believe it's the first time I've clocked it anyway, and it's kind of yeah, I've always been taught start low, escalate. This is a table where it's like based on the current level of asthma severity, start at this level. So of preventive therapy. And essentially it's like if you've had a severe exacerbation, like been in ED, needed oral corticosteroids, it advises starting higher, which makes sense. And I think a lot of us were doing that anyway. And whereas if it's someone with relatively mild symptoms, it's the usual start low and escalate. So I think that aligns with exactly what you're saying. I just mention it because I think if you're not sure what to do about like where to start someone in terms of their preventive therapy, that's a useful resource. I think I saw a comment in the chat, although maybe I misread it, but I think it was a comment about would interval symptoms affect your threshold for starting a preventer. And yes, so if someone's having exacerbations with each virus as well, but but they're completely fine in between. I guess I'm less likely to push a preventer, although I still have a very low threshold for it, as opposed to, whereas if they're having some interval symptoms, as in, you know, they're needing Ventolin twice a week, every week, then I would really be pushing them pretty hard. So even if they were steroids, they wanted to avoid a preventer, I'd be saying, I really think you need this, and really trying to convince them.
Yeah, and I think that comes down to really knowing your patient and the history taking, and that's where I refer back to community asthma program again, because asthma can be so difficult with interval symptoms. You can see someone with a post-viral cough that lasts 4 weeks, and then they've got the new virus 2 weeks into that, and they've got another fever, and they're sick again, and teasing out what is interval symptoms and what is just back-to-back viruses. This winter is easily successively the next worst winter after COVID I've seen for recurrent viral infections. Everybody I'm swabbing's having 3 different ones at once. So it's really tricky, but I find referring to the community asthma program is really useful then, just for that extra education advice to parents, because you rely on their history taking. And sometimes I've been caught out really thinking, yeah, this is asthma, but that the parents have been really well trained in the symptoms of asthma, and they've told you them, but it's not actually. When you see the kid, you're like, oh, that's not asthma. That's not asthma, right? Okay. So that's good. And we just say a little word on Alvesco, just because of the Flixtide Junior thing. I don't think anybody's really bothered about the Flixtide Junior thing. You just put it on a private script, and most people manage. And Alvesco is obviously once a day, which is easier, but they've been on Flixtide Junior and they were used to it and they knew it and they had it, so that's what we went with. But just for people who aren't familiar with Alvesco, it's an alternative for 5 and up. 5 and up. It's a once daily dosing, so that's helpful. It's got a round mouthpiece, so it doesn't fit in the hard spacers, which is annoying. So you do have to check that, or they won't be able to put it in their spacer. But it's just an option if you're starting a preventer. And again, you've got compliance and concordance to think of. Right, so it's 7:59. We need to move on. Thanks, everybody. So Melbourne Health Pathways, we always have a little blurb about this. I know a lot of people in the community don't use Health Pathways, but it is actually really good for things like exactly what Shiv said. Gina's come out with new guidelines and nobody's up to date with all the guidelines across everything. I didn't even know they had new guidelines in the last 1 to 2 weeks. So this is about as updated as you're going to get. Health Pathways, it's easy to use, and it's got emergency care. So if you've not seen a sick, queasy kid in a while, and you're like, oh God, what do I do again? It's got the emergency care, it's got titration of chronic care as well, and it's got referral pathways for respiratory. So it's a really good resource. And this next, thanks. Just the wrap up. So just the next slide, if that's right, Natalie. Your feedback's really important to us. And at our last working group, we went through the feedback. And it was amazing. So thank you. It was really, really reassuring to see how much people were getting out of the sessions. And we directly organised the sessions around what is fed back to us. So yeah, please answer the survey if you can. The video recording and all the resources, we troll through the chat and take out all the resources, and we'll send it to you in the post-COP email. And if you want to keep up to date with ICAM news, you can access it through that. And then if we go to the next slide, there should be one of these things, a QR code, not QI code, to access the survey if everybody doesn't mind holding over that, or you can click on the link. And Shiv just pointing out in the chat there, if you're not monitoring it, that you can use Alvesco off-label in under 5s. And then our next community of practice won't be in 2 months' time. We are going to put a hold on that because, long awaited, we are going to attempt in September to do a half-full training day. So last year at this point, we did a summary session where we got all the speakers in. We talked through a summary of everything we had learnt from the community of practice, sort of the highlights, the take-home points. And as opposed to doing that in Zoom style, we decided it would be great if we could look over the last 2 years and get those people face to face for an education day. So provisionally it will be held at Sunshine Hospital sometime in September, which is Asthma Awareness Month. We'll be contacting most of the people here to see what they can provide, and we'll be discussing it with the next 3 working groups to put together a really useful and interactive day. We will definitely have asthma clients attending to tell us their story, because that's always great. We hope to lean on our community asthma programme, our hospital services, our junior doctors, our GPs, Kevin, Danny, everybody, allergy specialists, yeah, everything really, to have a really holistic look at asthma and our learnings from the last 2 years. So stay tuned, we'll be emailing details out about that. I think that's all I've got to say, everybody. If members of the working group don't mind just staying on for a couple of minutes, we'll keep it short and everybody else can log off. Thank you so much for joining us, and thank you so much to our incredible speakers today.
And thanks for expert facilitation, Kirsty.
Oh, thanks, Shiv. Did you have any crying intervals?
No, which is great.